So tonight, glass ionomers in action. Basically, a product category I can say I've worked with over the last 40 years. Their value has been immense in my career. Their success has been really notwithstanding everything the literature says. I have really been able to witness. So, with that, I want to just say special thanks to SDI. SDI is one of the companies at the forefront of glass ionomer technology, and they are a proud sponsor tonight. We're no doubt going to be doing a hands-on component tonight, along with obviously a didactic course. If you don't have the hands-on equipment or what's been supplied, as Lisa said, there'll be an opportunity for you to get your hands on it after this program, and again, get to understand the versatility of all of SDI's products. So in the last, I'd say 20-ish plus years, these have been the mainstay products that I have used. And these really come in two categories: glass ionomers, which are in the bottom rung of these images, Riva Self-Cure from SDI, GC Fuji 2 LC from GC America, and Ionostar Plus from Voco. Those are traditional glass ionomers with no resin. When we talk about resin modified glass ionomers, which do have HEMA and resin that are light curable, the top three, Riva Light Cure from SDI, GC's product from obviously GC American Ionolux from Voco, are all, in my world, they're all just wonderful products. Somewhat different delivery systems, somewhat. But again, it's all about what will work best in your hands. I can say these products all act wonderfully within our patient usage. So I think the best way to start tonight, and it's kind of crazy. I was just on with a group of young dentists, and the majority really do not have any clue about glass ionomers. And given the wherewithal that these have been around 50 plus years and they continue to get better and better, let's dive into the advantages. The first is you don't have to bond them in. You're going to either condition or etch the tooth, and we'll get into that technique. No bonding agent. You basically load and either wait for self-cure or you load and light cure. They chemically adhere to tooth structure. And with that chemical adherence, you get a fluoride release, but you also get either an added calcium release or a strontium release. Both these added ions have very much a value add, and they have a synergistic effect with fluoride, both on the karyostatic mechanism and the remineralization process. So again, if you look at just this slide, quite a few advantages, but there are far more. There you are working in your oral environment, and oftentimes you can't isolate an area. Isolation is not an absolute with glass ionomers. They can be delivered in slightly moist environments. They have much less shrinkage and less shrinkage stress than traditional composites. They have a modulus of elasticity, similar to dentin, meaning the flexibility, and their thermal expansion, hot and cold, very, very similar to tooth structure. This gives them distinct advantages over composites. Disadvantages. You really can't put these in heavy occlusal function. They just wear poorly. They're routinely not as aesthetic as composites. They're not meant to be placed close to the nerve. And they definitely have less flexural strength and compressive strength in comparison to a composite. So these would be disadvantages. So really, what you have to really think about is where would these be applicable versus where are they not applicable? And in my world, composites are absolutely not the end all be all. And I do a lot of direct restorations, but I can say are not the end all be all when talking about composites. So when you look at indications in our practice, one of the ones that most people don't understand is you can use sealants that are glass ionomer sealants versus resin based. And again, even though the literature will say glass ionomer sealants can break down faster than resin sealants, even when they break down, their remnants are within a fissure, and that means they're releasing their ions within a fissure. So even though they may not be purely intact, and I'm going to say this again, even though they may not be purely intact, in high-risk patients, they bring great value. You can use these in small class ones, not in occlusal function. You can use them as bases under posterior composites. I'm going to show you a small class 1 technique and as a base tonight. You can use these in class 5s. You can use these in implant access holes. You can use these as small core buildups. You can use these as subgingival restorations where isolation is very challenging. And this comes into true usage in geriatric reparative dentistry with or without silver diamine fluoride, which we will touch on at the conclusion of our course tonight. So I really want to highlight just a few patient cases tonight. There'll be really, I think, 3. So Becky was a new patient at 17. This is pretty much the youngest kind of patient I see. I don't see children, even though I guess you could call 17-year-old a child, but I don't. I look at them as a teenager. Children would be really 10 or less in my world, but whatever. That's my own issue. Okay, so she had terrible oral hygiene when she came in. She was a once-a-day brusher, not a flosser. She already had multiple class 1 composites that had recurrent staining and marginal breakdown, and she's only 17. She admitted high sugar intake via soda and snacking. And so what we did was we did a GC Saliva's buffer test, and her buffering capacity came in at moderate. Not horrible, but not normal. And that color is blue on the buffering kit. Her saliva flow at 17 was normal, and her resting pH was normal. Okay, that's her initial workup. So she's got current restorations that are breaking down at 17 already. She's got really crummy oral hygiene, poor diet, lower buffering capacity. And my explanation to all of you is she's a high caries risk patient. So the first takeaway tonight is you need to identify your higher caries risk patients. There are many other things we could get into on next webinars and podcasts, but in my world, you have to identify normal caries risk versus high caries risk. And so as I did my literature review for this course tonight, this article, which really went huge in depth, is 2 years old, about the preventative effect of glass ionomer restorations on new caries formation. And basically, the bottom line from this review article, was glass ionomer restorations presented a better preventative effect on new caries than other restorations in primary or permanent dentitions. Obviously, other primarily would be a composite. So here's the technique. So Becky comes in, she's got an early, I'd say D1 lesion, early. I could prepare this and by using articulating paper first, just to establish her baseline of occlusion, I knew that she would not be in function with this final restoration. So higher caries risk, she's not going to be in function on this small preparation. My treatment of choice was a glass ionomer. Whether you want to use a resin modified or just a self-cure glass ionomer, and I don't mean just, but a pure glass ionomer, that's up to you. A pure glass ionomer is a bulk fill self-curing with lower compressive strength and higher fluoride release versus the traditional resin modified glass ionomer. And we'll touch on this more. So the technique really applies that you're going to etch the tooth for 5 seconds with your normal phosphoric acid, or you can use a dental conditioner. I showed the two we use in our office, GCs and STIs. And it's a 10 to 20-second application. My feeling is if I'm really conditioning the enamel, I'm going to go 20 seconds. Certainly not going to be detrimental to the dentin as it removes part of the smear layer and conditions. You're not going to over condition the dentin at 20 seconds. DFUs will tell you 10. So the product line is very interesting from SDI. They have 3 self-cures. One is their normal Riva self-cure. Then they have a self-cure fast set. And then they have a high viscosity self-cure. Now, the high viscosity does not have a fast set. So really, in the hands-on kit that you all got, we won't be using the self-cure for the hands-on. You should absolutely try everything that was presented to you in the kit and see which handling you like. I love fast set, but I also like high viscosity. So you're going to kind of have to really try it for yourself, but understand there are 3 different offerings there. My preference would be to tell you you're either going to use Riva Self-Cure Fast Set or Riva Self-Cure High Viscosity. That would be my preference if I was to order 2. So how easy is this to do? The first thing you're going to do is you're going to tap the capsule to loosen the powder before you triturate. Then you're going to push the yellow plunger down. We're going to get into this in the hands-on. Then you're going to triturate for 10 seconds. So you just shake it up first, push the yellow plunger down, triturate for 10 seconds. And after triturating, you're just going to place it in your syringe and start loading your restoration with your glass ionomer. Overall, with a glass ionomer, my feeling is that you have to let it go through its initial set. Now, I will tell you the initial set in the regular viscosity is a little loose for me, like most glass ionomers. I love the high viscosity. So I don't feel I have to wait for a long gel set to occur. I can almost immediately start packing. But if you're going to use the Riva Self-Cure Fast Set, you're going to see, wait about 10 to 20 seconds, let it get into its gel formation, then start packing it in. And again, this is a bulk fill. One option that I've used for years to create anatomy is you just take a little piece of a Ziploc bag, cut it out, so you have a little plastic sheath. After you inject your glass ionomer, just place the plastic sheet over it, have the patient bite down, just set your timer, and when the material's set, just have the patient open, take out the plastic sheet, and now you have basically your anatomy all done. That's really the easiest way to, in my world, to carve or place these materials. Once that's done, then what I will just do is I'll just do some finishing and polishing with ultra-fine diamonds or multi-fluted carbides, just like you'd finish with a composite. That's what I'm going to do, and I use plenty of water. Now, part of the success of this is using what I would call a self-adhesive nano-filled resin coating. This becomes imperative when you're working on glass ionomers, not resin modified, but pure glass ionomers. So these nano fillers will protect the restoration really from wear, and it really allows the glass ionomer more protection as it really continues its setting over the first few months. It's about 80% cured after 4 or 5 minutes, whatever the final setting time is, but the material will continue to really, I would say, fully mature over a certain period of time when that patient leaves the chair. This will protect it. This will protect it from saliva and water. It's really a glaze. The material is hydrophilic, so it will actually flow. So I basically place one drop on. I just spread it. There's no air drying at all. Just spread it nice and thin and light cure for 20 seconds. That's it. That's the recipe in order to create a beautiful posterior class 1. Now, I've done these on my kids, and I can tell you I'm going to do what I think is best on my kids. And if they're not in function, as this glass ionomer isn't, I'm always thinking about longevity. So when you practice long enough like I have and you don't move every 5 years, I'm just going to show you this is what I see long term. In 1984, I placed a small class 1 on this patient, no occlusal function. This was in 2013. She moved in 14. So this is my last picture. No brown lines like in a composite. Yeah, you don't have tooth anatomy. Get over it. Who's looking at that? I mean, come on. What are you looking for? You're looking for, how do you define success? This is, to me, successful. It's in the mouth 40 years with no recurrent decay, no staining. This is what I expect when I use a glass ionomer in this kind of situation. When we look at controlling secondary caries, another review and a meta-analysis. And I think what's interesting here is they came really up with the same conclusions. The same conclusion as you read this slide was that glass ionomers are truly more effective and resin modified in minimizing secondary caries than composites, amalgams, comprimers, and even gyomers. So I want everybody to understand this, that I know there's a lot of technologies out there, and I'm not opposed to them, but I'm going by the literature on the literature review. Now, I'll also say, as I reviewed this for tonight, if you have a patient who's got a low caries risk profile, their diet's good, their saliva is good, their oral hygiene's good, the literature really says composites and glass ionomers will really have similar success in regard to secondary decay. So the takeaway from this first part of the course is really define with your patients who's high caries risk, how you're going to treat them versus low caries risk. So part 2 of our 3 parts tonight, here's the RMGI portion of the course. So this is a product from SDI called Riva Light Cure. And the orange tip is the distinction in the capsule in that it prevents premature setting. So if you're going to layer a Riva Light Cure or RMGI, and basically they are layered in 2 millimeter or 1.8 millimeter increments, if you're going to have to layer or you're going to do multiple restorations in one visit, the orange capsule, the lid, really allows the material not to set after you've placed your first layer. In general, all RMGIs with resin have higher flexural strength than glass ionomers, better aesthetics than glass ionomers, better long-term resistance and surface hardness versus glass ionomers. You don't have to put a Riva coat or a GC coat over them at all, okay? Sealing is not required. And they're available in a regular or high viscosity. And we're going to sample out in our hands on the high viscosity. But after this tonight, try the regular viscosity. I'm not going to tell you what you like. I just happen to love the high viscosity. So we're going to do our demo right now. We're going to go through these 7 steps, and there will be a PDF after this course for anybody who wants the PDF of these slides. They're all in the PDF that you can request from Lisa, and she'll send them out to you. Okay, step one. You're going to tap the capsule a few times. So I want everybody to get out your capsule who has this, tap it, and then you're going to activate your capsule by pushing down. So now you've activated it. And now what are you going to do next? Next, you're going to triturate it for 10 seconds. So after the 10 seconds, and honestly, I will just tell you, I think any amalgamator triturator is going to be fine. After you triturate, you're just going to load it in the gun. And I want you all doing this right now. So I hope you're following along. So load it in the gun if you're doing this at home. And now what you'll do, SDI has provided you multiple little plastic models. As you inject, try to keep your tip in the material. You have plenty of work time. And in real life, you would have already etched or conditioned the tooth. With 2 minutes plus of work time, which is way crazy, I will tell you that all you're going to basically require is probably about 30 seconds to remove the excess, do a little carving, and call it a day. Now, this is what you can be playing along with at home. But I would just tell you right now, you should be getting a feel of the high viscosity of the material, the packability of the material. Now, for those of you who have the hands-on kit, later triturate the not high viscosity and see what you prefer. Then you can compare it to the self-curing bulk fill glass ionomers. It's kind of like by having the kit, you get to feel like a sampling program of what you want to use in your practice. And there's so much in the hands-on kit, you can obviously use it in your practice this week. Light curing. You're going to light cure now for really 20 seconds. Again, any good light is going to cure your RMGI. Then you're going to finish and polish the restoration. As I said, multi-fluted carbides, very ultrafine diamonds, just like composites. Now, here's what's amazing. After or later tonight, take the material and inject any leftover into your next model. And you'll see the orange tip really protects the material, so you can layer with this. So if you're deeper and you're placing more than 2 millimeters, you can actually layer your RMGI this way. Or if you're just going to go to another class 1 or a class 5, you could use it and obviously save yourself the money of using multiple capsules if you don't need them. Again, it depends how much you use on the first and then what you have left over for a second restoration. I have found no more than 2, just letting you know. But as dentists, we love to save money. And I think the orange tip really allows that. And if you have questions, we'll answer the questions at the end of our course. Okay. So I want to make sure everybody's gotten through that little bit of the hands-on. The PDF will be able to have anybody go through it again. And obviously you can visualize this again. But you should basically just realize you're going to tap the capsule. You're going to then obviously push it down, push the capsule down to activate it, triturate for 10 seconds, lock and load, start backing, light curing, and it's that simple. I mean, it's that simple with all the value of an RMGI. So let's take you to case number 2. New patient Michelle, who was 26, actually working for Septodont at the time. She comes from a dental family. She had no restorations in her mouth, great home care, ortho as a teen. So she had seen the same dentist routinely for years since she was a kid. Her last visit was 8 months ago, and her dentist was her dad's older brother. So again, I want you to realize she technically was low risk coming into my office with great home care, ortho, and no restorations at 26. So ideally, you think she's low risk. Okay. So at the time, I was using Logicon, which was made by Kodak, Diagnodent from Cavo for evaluation, for caries evaluation in my patients. So here's her x-ray. Logicon, still available, by the way, uses a very cool, it's not AI, but it uses a logarithm to evaluate if there's class 2 caries, far more detailed than an x-ray. It takes an x-ray and gives you far more information, and then Diagnodent. And I'm still the biggest Diagnodent believer, and you'll see this in this case. So what did I trust more? I used an Explorer on her. There was no stick. And yet on a Diagnodent, her reading on this was 58 and 68. Anything above a 30 in my world was caries, really into the dent. And that's how I looked at it. So I've got no stick, but Diagnodent is reading a 58, 68. Anybody out there who uses a Diagnodent is going to say you're going to have to drill. I could see a little brown halo. So now I'm using my eyes, still no stick. I opened it up with a fissurotomy. There's my initial brown halo. I'm opening it up. And you saw the x-ray. And x-rays are tough, obviously, at times, and very challenging. This is the hole. Yep. So 26 years old, she's been going to the dentist. And I would say just misdiagnosed, because what dentists normally do is they use an Explorer and an x-ray, and both have huge, what I would say, false negatives, huge false negatives. So in this case, and I'll go through this, her caries were moderate in depth. Yeah, it looks like a big hole, but when you see it on the x-ray, it's deep, but not that deep. It was not approaching the pulp. And if I'm approaching the pulp, and I'll get into this in about 3 slides, then I will use a liner. I can't put a glass ionomer as a base if I'm near the pulp. It's contraindicated. You'd need to use a liner. I would use a calcium hydroxide liner. Now, at this point, I've got a hole, a good size hole. And really, these are your options today. Let's start with number 1. You can do a bulk fill with a traditional bulk fill composite, which you all have, in 1 or 2 layers. And then you could use a bulk fill flowable also. And then you could cap them off in a final with a final material. Now, some bulk fills, like Voco's Extra Base, it is a beautiful bulk fill that really finishes beautifully. So you don't really have to have a final layer. Again, it's what you have in your armamentarium. Another hot product category is the bulk fill dual cure composites. And then the question is, do they need a capping layer based on really where? And I can tell you also that a bulk fill dual cure material that SDI has, which is called Stella, is absolutely a potential game changer based on its primer and how it self-cures. And that's a self-cure bulk fill. And there are others coming out. Clinician's Choice has their own bulk fill dual cure with exceptional properties. You can use a bulk fill that's fiber reinforced to be a dentin replacement, then it's layered. An example of that would be Everex from GC America, an exceptional material with small microfibers intermixed in the flowable. and with a flexural strength and a fracture toughness higher than any flowable in the market. You could rebuild like you normally do after drilling with some flowables and composites. And in this case, I decided to rebuild her with an RMGI and then cap it with a composite. So why? What would be my decision making? What goes on in my brain? Well, that's a challenge in itself. The first thing we all know is hybrid layers over time break down. They do. I don't care what anybody says. We know they do. So over time, if you're just bonding, those layers will break down. Now, I personally have had great success with composites. I meticulously followed the directions for use, but it's still well known hybrid layers break down over time. RMGIs and GIs in themselves has a modulus of elasticity similar to dentin. Composites do not. RMGIs create far less shrinkage, and less shrinkage strain should be strain, not stain, when being performed. They chemically bond to dentin, so they're not the same mechanical bond as in a composite. This is a chemical bond. And again, they're karyostatic and they can enhance remineralization. So for 30 years, I've been using this as a dentin replacement. Now, it takes a little bit more time, but I'm going to tell you, when you see this technique, I'd rather have this in my mouth than most other techniques for moderate to deep class ones. And even in class twos, I'm just not going to put it on the floor. And that's another discussion. I don't believe in open sandwiches. But in this case, to be clear, I'm going to use it as a base. Could I have left some decay? Of course. I think we all leave decay. And the studies go, if you're deep, you have to keep a remaining dentin thickness above the pulp of anywhere from, I believe, 1 millimeter to 1.5 millimeters. So you'll see on the x-ray where we're at. So in this case, I'm going to apply the conditioner for 10 to 20 seconds. I'm going to rinse. I'm going to lightly dry. And usually I'll just use my surgical suction to go in. That's what I'm going to do. Just a surgical suction going in. These are your options. Now, other companies make resin modified glass ionomers. I just don't work with those companies, so I can't comment on them. I work with GC, SDI, and VOCO. So here's the clinical steps to get to the picture on the right. I'm going to inject the RMGI slowly. I'm going to usually use a wetted composite instrument to pack it into place. You got two minutes plus of work time, and you must light cure for 20 seconds. And again, it cannot be thicker than 2 millimeters. If you're going to do a bulk fill, then you're going to want to use a pure glass ionomer. And again, the theory is that if you're putting a composite over a glass ionomer, it's potentially better to do it over a resin modified glass ionomer. With SDI, I'd be dipping with Revacoat, just letting you know. So the next clinical steps are, if you need more with the orange tip, you can obviously place more. I'm then going to re-prepare my walls to make sure they're clean, my enamel walls. I'm going to re-prepare them, and then I'm going to put a final bevel on my enamel with a red diamond finishing burr. Okay, so I basically have bulk filled it. I mean, placed 2 millimeter. That's my bulk fill, so to speak, light cured. I'll then re-prep it. If you want to re-cure again, you can re-cure again. But again, no thicker than 2 millimeters. And at this point, I'm ready to start placing my composite. At this point, I'm only dealing with enamel. So total, that's 15 seconds. You could go longer. I'm going to rinse, blot, dry, suction dry. Then I'm going to apply my bonding agent. Usually it's a universal bonding agent. I'll show you on the next slide. And these are the options. You could apply a little flowable, light cure for 20 seconds, then your final composite. Another option, just place a composite on the buccal, light cure for 5 seconds, then place it on the lingual, and then light cure that lingual and buccal for 20 seconds. That way I'm minimizing my C factor versus just playing one large layer. I want to minimize my C factor, which would create more stress and strain. And one of the best ways to minimize stress and strain, use warmed composites. I am telling you, warmed composites are a home run. I love the flowability. I love the packability, but I also love the characteristics that you get out of warming a composite to minimize what I would say stress and strain. Minimize, not eliminate, but minimize. So composite warmers, home run. They've been a home run for 20 years in my practice. So these are the universal bonding agents, and there's so many more out there from so many different manufacturers. This is what I routinely daily use. And in this case, I'm really bonding to enamel and dentin. I'm sorry, enamel and my RMGI. That's it. I'm not bonding to dentin. I've already have my dentin replacement. So when you look at it, the remaining dentin thickness is not an issue. You can see I am far more than 2 millimeters from the pulpal horn. Obviously, this caries were there a long time. Why would I say that? Because you can see that probably the pulpal horn has receded. Just, it's a learned technique that you understand diagnostically. The red line differentiates the RMGI, which is very radio opaque, versus the composite. The RMGI is a dentin replacement with more dentin characteristics covered by a final layer. Yeah, takes you about 5 extra minutes to do this, maybe 4. I know you're all dealing, so many of you are in PPOs. My heart's out to you. I understand all that. But what I would tell you is, whether you want to call this maybe an added indirect pulp cap to this procedure, I'm not going to go there, but I will tell you, to me, this is the class way of providing a long-term restoration. And when that composite starts to leak, and they will start to leak over time, now you've got an RMGI below it to minimize what I would gauge secondary caries, which is how I started our course. This is what it looked like. I placed a small sealant, obviously in the remaining grooves. She stayed in my practice 7 years. It looked like this 7 years later. If you take the time to do this right, my feeling is at 26 years of age, I want her to have this restoration for 20, 25 years, not 5 or 6 years. And my signature is this restoration in her mouth. That's the long-term success. So let's finish tonight with a little hands-on and a little understanding of silver diamine fluoride and a patient case. So my feeling is silver diamine fluoride, I'm going to show you in about 5 slides why it's very preventative, and it also creates new, unique restorative opportunities in your practice. And we're only going to touch on it tonight. What you have to understand is, you all know it's a solution that contains silver and fluoride. I know you know that. Those are the active ingredients. And when you're using silver diamine fluoride, it is off-label to use this to arrest decay and promote remineralization. It's off-label. It's crazy. But I'll show you what on-label is in the next slide. But what is silver diamine fluoride? I want you to understand it has an antibacterial effect, and it has a tremendous remineralization effect from the silver particles and the fluoride particles. Huge. Now, when you look at Curidont, which is another amazing product that we have in our practice that I again say is a must-have, it works totally different in how it remineralizes and rebuilds enamel. two different modalities entirely. But what you have to understand is that when you're using this, and oftentimes, and I'll show you the case, what'll happen is if you use this on what I would say moderate depth carries, or not just so moderate depth, could be earlier carries. This will, when you place this, it will inhibit strep mutans from adhering to the tooth surface and also have a huge antibacterial effect. I will say this to you based on the literature without going deep. SDF should not be placed near the pulp. SDF should not be placed within a millimeter of the pulp. It has been shown to travel through what I would say called the dentin. So it would be absolutely safe to use in the previous case. We were so far away. But again, there are so many understandings of how to use this properly. So on label, there it is in blue. Desensitization of teeth. What I can tell you is that for me, I have used it in my practice for the last number of years for caries management in the bottom row to arrest caries and to prevent recurrent caries. I really haven't used this in children because I don't see them. The product that we have been using in our practice for the last, I don't know, I'd say 2 years, was a game changer for us because it makes the technique even easier. There's no ammonia in it. Traditional SDF, you just want to pass out when you're applying it. This product has no ammonia. It's a water-based silver fluoride solution. I'll show you the study. It's as effective per the study that I have read in other studies as traditional silver diamine fluoride. But this is a two-part system. So Revastar Aqua is a water-based silver diamine fluoride that is followed by potassium iodide. So it's a two-step. Let's go with step one. As you apply what's in blue and you scrub the tooth, it has a pH of about 5 versus the traditional pH of very basic and caustic above 10. So it's literally slightly acidic. You really don't get soft tissue irritation, which was always a problem with silver diamine fluoride. You don't have the odor. You don't need to use a gingival barrier. And I find the treatment time very, very quick, and we'll walk through the technique. The potassium iodide basically is immediately applied after step one. And we'll go through this. And what you will see is that as you apply this, the idea is the potassium iodide is going after any free silver ions that are being released from your SDF. What this will do is it will minimize the blackness that occurs with silver diamine fluoride. It's also highly bacterial, and it also then basically works as you apply it, you'll see this white, opacious, pasty look. You will keep scrubbing this until it disappears fully. That's the key. You just keep scrubbing, and that removes all the silver diamine, the silver ions. Then you simply blot dry if you're not restoring, or you rinse for 30 plus seconds at this point if you're going to restore. I still will tell you, you will see some blackness. Absolutely nothing like traditional silver diamine fluoride, but you'll still see a little bit of darkness if you don't restore the tooth. And that darkness could come from recurrent decay some decay that's left after you've done prepping, or some just really demineralization that's present. So let me pause here. For the hands-on portion, I want everybody to get out the sandpaper that's been sent to all of you. Get out the sandpaper and get out the capsule, the blue and the green capsule. Okay? Everybody get it out. So step one in this is basically you pierce through the blue capsule, pierce through it, then take your brush, spread it along the sandpaper, you can go back in and get some more. Just spread it. Now, step 2. Now pierce the green capsule. And what you're going to do is you're going to apply the potassium iodide. You'll see the white precipitate, the free silver ions. Just keep scrubbing. Scrub, 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 scrub until it's clear. Once it's clear, you're done. That's how simple SDF is, the application procedure. In the mouth, you can now just basically blot dry, have the patient go home, or restore via rinsing. And that's what we'll get into in our last clinical case. The effectiveness of silver diamine fluoride. The effectiveness in a geriatric population, as this study showed, and this is already 9 years ago, I want you to see the clinical effectiveness. And what we're seeing in all of our practices, our patients, and a typical one I'll show you coming up. The fastest growing age group that we're seeing in our offices are patients 85 and older. They have huge caries risk, along with perio risk. How are we going to treat these patients? So the study showed, in this case, where 64% of the patients returned after initial treating their root caries. The first group was treated with varnish. They had a 45, what I would say, arrest rate. Group 2 at 90% with traditional SDF, and group 3 with SDIs. I think this was Revastar when they had ammonia, but now it's Revastar Aqua, had a 93% arrest of root caries. Think about geriatric patients and think about 90 and 93%. Varnish is not your answer. SDF. Without tissue burn. Again, PDF will have all of this. There's your bill per tooth, and we would charge a varnish application per tooth also, if you're not restoring. So let's finish tonight with Jim. 91-year-old guy who comes and visits his grandkids in Chicago. His dentist back in Colorado identified many cavities and told him basically, you're medically unfit to go through treatment and you're old. His history is beyond prostate cancer and remission. He's got very bad aortic disease as confirmed by his doctor. He didn't want x-rays, didn't want crowns, didn't want shots, but he wanted to minimize future drilling. So how could we minimize his cavities from growing, AKA SDF? So when I look at SDF, I look at it as both preventative, reparative, and it can also allow you to do patch type dentistry. And anybody who says patch type dentistry is bad dentistry, then let them come to my practice. This is how I often treat the elderly. So here's his scan showing you huge carie risk issues, more on each side, maxillary and mandibular, and his lower right really the worst side. So obviously you can see the large lesion, but let's now talk about, this is typical geriatrics, rampant decay. Now you can talk about remineralization trays, and we can get into all that on subsequent courses, but let's take a look at him in Pearl. So we're a Pearl office. I really believe in 2D AI. I know there are a few leaders in it, and I think they're all wonderful adjuncts, whether it's Overjet, Pearl. I just think these are great companies. So here's Pearl. Pearl, if you don't have it, my hygienist and dentist in my practice would all tell you it's a must-have. It works by identifying through AI a variety of issues, and it then color codes them. Pink is the color code for caries, and he's got caries in all four quadrants. We're only going to look at one tonight because of time. So this is black and white images that you all have without 2D AI. With 2D AI now, I can highlight the decay. It tells me how deep the decay is, and there's a 20% margin of error. You can look at all these little issues. This is just one bite wing. And you go, what are you going to do for this patient? And when I go back here and talk about this one, I'm going to look at the periapical. And of course, I took x-rays. I'm not going to let them tell me not to. If the patient's asymptomatic, and in my practice, we take bite wings and a cone beam, and the cone beam is going to show me if I have any periapical pathology. PAs just miss too much. So I'm going to rule out periapical pathology. But what are you going to do here? What are you going to do on a 91-year-old? Just going to watch this? You're not going to use Curaden here. This is cavitated. So what are you going to do here? So option one, you can apply SDF biannually with no drilling. That's what the study showed, biannually. You want to bring them back 2 or 3 weeks later and apply it and even make sure you can do that in 2 weeks. But the studies have shown biannually. So what do? You use a non-fluoridated prophy paste, rinse it, then you apply Revastar Aqua and immediately apply part 2, the potassium iodide, and scrub until the whiteness goes away. If you're not restoring, in this case, you just gently blot dry and you apply the varnish. That's your first option. And again, you'll have this on a PDF. Option 2, this is Comet Cerabur. It's a burr that only takes out infected dentin at about 1,500 RPMs. It's from KOMET, the company Comet. In this case, I remove the plaque, I remove the infected dentin, and I'm not even making sure I'm removing it all. I'm removing most of it. Then I etch for 15 seconds. And after etching, I will then rinse, blot dry. I'll apply Riva Aqua, and then immediately the potassium iodide, scrub until it's clear, and then gently blot dry. And again, apply varnish. I prefer to apply varnish. Okay, it enhances more fluoride in the area and protects it. Last option. Again, I'm going to remove any loose plaque with non-fluoridated prophy paste. So many companies make them. I'm going to remove the infected dentin. But now I'm actually going to go to the next step. I'm going to bevel all my margins. Why? I want to create a better seal. I want to make sure everything's seal tight. I'm going to etch for 15 seconds after beveling, rinse, blot dry. Then I'm going to apply Revastar Aqua. Immediately after applying it, potassium iodide scrubbed in again, same technique. But now instead of blot drying, you're going to rinse the area just to remove any free silver ions and the potassium iodide. So you're going to rinse for 30 seconds. Why? Because I'm going to restore it. And I want to restore this. I don't want this to just be a food trap. So I'm going to restore it with an RMGI. More durable, stronger. So now I'll apply the dental conditioner. He's totally not numb. He doesn't need to be numb for any of this. So I'm going to apply the conditioner for 10 or 20 seconds, rinse and blot dry. Inject your RMGI. Put a Mylar strip down, just pull it tight, like Cure. Take off your Mylar finish and polish. Now you can use a composite. You could use a regular glass ionomer. That's up to you. But he's 91. I am doing definitive reparative care and sealing him. The picture on the right shows SDF with typical staining around a glass ionomer. Revastar Aqua on the right side showing you much less black staining. hence why I love the potassium iodide step 2. Our goal tonight was to share alternative restorative options for your high caries risk patients, and we know our practices have tons of them. Also, a way how we can build bases or small core buildups underneath our crowns and composites to create a chemical bond that I think is more bacteriostatic and really far better for the patient. I'm always thinking longevity for the patient. That's my mantra. Okay. I really love sharing all of this with all of you. I'm going to stop sharing. I'm going to take some questions. So the effect of the etch on the GI from Donna. So Donna's asking, if you use a glass ionomer base, what's the effect? So Donna, the studies vary, but they will say etching a glass ionomer that is not a resin modified glass ionomer can disrupt the surface integrity. So that is why, Donna, most people are recommending in RMGI as a base, because the effect of the etch on the glass ionomer. Now, to that point, Donna, most of you at this point are selective etching. So if you're selective etching, the effect on a glass ionomer is irrelevant. It's only if you're total etching. So I think on a total etch, the glass ionomer surface can be disrupted, not as much on an RMGI. And I can tell you, I've taken out 10-year-old composites where I see marginal leakage and I don't see leakage at my glass ionomer interface. So that would be my answer to you. And if it's concerning to you, absolutely try to do a selective etch. What is the name of the manufacturer of the infected dentin removing burr? So the name of the manufacturer is Comet, K-O-M-E-T. The burr is called a Syrah burr. It comes in 8 different sizes. It is meant for slow speed only, between 1,500 or 1,000 to 2,000 RPMs. We've been using it for over 10 years, and you see little shavings come out. And when the shavings stop, you know you've removed all the infected dentin. It should not take out caries affected dentin, which I don't want you to take out. Donna asks again. Donna's got good questions. Okay, Donna, do you always use a conditioner? What about in patients who cannot not tolerate the rinse or suction? I don't know, Donna. I got to be honest with you. I've been practicing longer than you have. I have not had a patient that really had any problem with me doing a localized rinse and suction. I'm not challenging you, but I do believe the conditioner does remove the smear layer and condition the dentin. So I still believe in the system. I know it's a self-etching material, but I still like to remove and clean, at least do a partial smear removal. So that's what I would tell you. I still would condition. Okay, Wansik asks a question. Can you use Revacoat as a protection coating layer over resin composite, just like Permaseal? I would tell you I don't know this. I would say this to you. That could be a question you can ask SDI. The problem over composites, Wansik, that I have found is that when I place a final protective coating after I've adjusted my bite, all too often the protective coating on the composite makes the composite high. So I really don't like putting a coating over a composite. I just don't. So I hear you. I tried it for years, and then all of a sudden my patient says after I've adjusted it, I put the coating on, and then they say it's high. So I'm just sharing with that. Also, he asked, can you share with me your guide to identify the high caries risk, medium caries risk, and low caries risk? Wansik, I'm going to ask Lisa to send you my email. Reach out and ask Lisa. That's a whole course in itself about evaluating high, medium, and low caries risk patients. Obviously, there are studies out about identifying it in many, many different ways. But I just want to share this with you. On all of my patients, I use transillumination to evaluate caries interproximally and occlusally. I still use diagnostic as a fluorescent mechanism. They're all far more accurate than an Explorer or just 2D X-rays. And obviously, I use Pearl to help detect that. I do use acid buffering tests to evaluate that. And now there are other tests that are basically oral wrist saliva tests that are very simple, a little bit more expensive, just to evaluate your caries risk patients. That would be my short answer to that. I'm happy to answer more at a later date. Okay, I believe, Lisa, I have answered all the questions. Let me ask you this. Hold on. Somebody asked, do you still use CaryView? I love CaryView. It was discontinued. So Cabo is now launching their new CaryView ultra high definition camera and fluorescence. So it is like it's called, I think, Diagonal Cam, whatever. It's look up Cabo's new Diagonal Cam. It offers all three in one. And I will absolutely tell you, transillumination is the least invasive way to evaluate class 2 caries, fractures, fracture lines, and so much more. And someone asked, do I like that one? I have not tried the new Diagonal Cam. I just haven't tried it yet. It's on back order and we're evaluating it at Catapult.